I'm going to talk about factors of risk and resilience in children. Most of my work is in Africa, but I think a lot of the things I'll be sharing are very applicable to an audience of European practitioners, as I think you'll see. First of all, when we look at the effects of HIV on the central nervous system, and particularly neurocognitive, neuropsychiatric function, we see quite a range of prevalence within HIV-associated neurocognitive disabilities or disorders. And this is using the same types of neuropsychological assessment protocols. For example, University of California at San Diego, under the direction of Bob Heaton and his colleagues, have looked at HAND, HIV-associated neurocognitive disabilities, all over the world and in different countries in Africa, China, and the Far East, and South Asia, and the United States, many different communities. Some in Europe, both Western and Eastern Europe, and they found quite a range of prevalence of HAND, 21% to 77.6%. When we've gone back and looked at their data, we've seen a strong association between the prevalence of HAND in their adults using this neuropsychological protocol that they've developed, that's culture fair and fairly universal, and the poverty rates as they would impact potentially upon young children in those countries. So I would dare say that a foundation to adult neurocognitive difficulties and neuropsychiatric difficulties, that the foundation of that is laid in early childhood in those very countries and in your communities and in your practices potentially. Now, as to how early childhood and poverty and other kinds of risk and resilience factors ultimately affects the likelihood of HIV-associated neurocognitive dementias, disorders in adults, those mechanisms are not well understood. But I think there are a number of factors that we're beginning to better understand that I'll share with you this afternoon. Now, the START trial was a global trial, primarily in low and middle income countries, looking at adults and focusing specifically on when should we start treatment for HIV. Should we wait, as was the standard of care in earlier years, till the CD4 cell count reaches 350 cells? Or should we just begin treatment as soon as adults are identified with this infection? And the bottom line is that looking at thousands of patients at hundreds of sites in 35 different countries, that we can reduce by as much as 53% the risk of developing serious illness and death, by as much as 70% other kinds of adverse effects associated with HIV infection if we start treatment as soon as we diagnose it, if we don't wait. And basically that's become the standard of care now, as recommended by WHO, and it's become the standard of care as well with children. The earlier we can start children, as soon as we can diagnose it, and with better diagnostic tests, PCR and other kinds of tests that we can identify in very early infancy, we need to start treatment and continue treatment as soon as possible. But what does that have to do now that we're able to treat more effectively? We've made treatment more available in low and middle income countries globally. HIV patients, now it's become potentially a chronic condition, not a death sentence. So what do we do as patients age? And what we've been running pilot studies now in Uganda, looking at aging HIV patients, some now on antiretrovirals with the disease going on 30 years. And we're finding a significantly enhanced risk of dementia, Alzheimer's disease, and vascular-based dementias especially. And we're working with Nwalin Nakasuja, the chair of psychiatry at Macquarie University, and some of this work is being led by my colleague Bruno Giordani at the University of Michigan, as well as by Amara Aziyamama at Michigan State in psychiatry. And basically we're seeing that curve of dementia and Alzheimer's disease, vascular dementia risk being pushed up about 10 years. As your patients age, your adult patients, look for earlier onset of these types of dementias and screen for it as well. And that's, I think the foundation for that risk for dementia is laid in early childhood. And I'm going to show you a mechanism because risk and resilience, it's a two-edged sword. It really comes back to plasticity, positive neuroplasticity, how we can repair the brain medically and behaviorally when it becomes vulnerable to injury through HIV infection and a host of other kinds of risk factors. So these three waves of brain development in the human species at birth, the first being more sensory motor, neuromotor, and then the brain mechanisms involved in that. But they form the foundation of then language and language development, beginning in very early childhood and extending through middle childhood especially. And then, of course, that lays the foundation for more prefrontal cortical executive functions of the brain. And basically, these three waves of neurodevelopment in children, beginning very early on, depends on experience. And I'm going to really emphasize that. The importance of the children and the families that you serve in Europe and Africa and Asia and America and wherever, to have really cognitively enhancing experiences that will facilitate these three successive waves of brain behavior development that will occur through childhood. And so, please, if nothing else, take this slide home with you, and I'll make these available to you as well. But basically, the first 1,000 days, when I go to other meetings pertaining to child development, particularly in Africa, but in low and middle income countries globally, the first 1,000 days, which include gestation, okay, have become really vital because it's in those first 1,000 days that we can make the most significant impact in long-term neural development across the lifespan, okay? Now, what happens in those first 1,000 days we can see in terms of, and I could come back to my earlier slides here, which looks at those three waves of brain behavior development, but in those first 1,000 days, there's a lot happening very quickly. It tapers off somewhat through middle childhood, and then even more so through successive decades of adulthood. But the impact of your interventions in establishing this trajectory of neurodevelopmental well-being for the child as that child ages through adolescence and through the successive decades of adulthood is vital. And that sets the stage then in adulthood for what we call the cognitive reserve. In other words, when the adult brain takes a hit through HIV, through other kinds of stroke, through other kinds of infectious disease or brain injury, how devastating will that be in terms of the neurocognitive well-being and function and neuropsychiatric function, because that's based in the brain as well, right? So what's going to happen to the adult in terms of that cognitive reserve? Well, that trajectory is established, and if the child's taking a hit from HIV, from other kinds of comorbidities, from neglect, from abuse, in early childhood, in those first 1,000 days, you can see what happens to that trajectory then across the lifespan, and particularly into those adult years. And you can see what happens to that cognitive reserve. Even if you make extraordinary efforts to treat HIV and to treat other kinds of comorbidities in the adult brain, you can only gain so much if that trajectory has been established in the first 1,000 days to be one of great risk and far less resilience. there's a threshold of what we define, depending on the culture, depending on the test, depending on the medical practice, as a threshold of neurodisability delay. And you could see then that your intervention to step up that at-risk population above that threshold becomes more and more difficult the longer you wait, okay? So each of these blue arrows, the size of which signifies the neuropsychiatric, neurocognitive, neurodevelopmental impact. So where is the best bang for your buck, so to speak, from a public health standpoint? Obviously, it's in those first 1,000 days when you can really set the stage then across the lifespan. So that threshold for cognitive decline and aging then occurs much later than with of highly at risk, with minimal resilient population. All right, well, we've done 10 years worth of clinical trials now in rural impoverished areas of eastern Uganda with families, households affected by HIV, with cohorts of children infected, cohorts of children exposed but not infected, and comparison cohorts unexposed, uninfected. And we found that what happens to the mother is probably as important as what happens to the child, and in fact, the best way to establish a neurodevelopmental trajectory that reflects resilience and less risk is to intervene as early as you can with the mother, even during pregnancy as part of your prenatal care package. And for the HIV-infected mother, it becomes even more critical, more important. Now, the CHER study that was done in both Cape Town and in Johannesburg, South Africa, again, at WHO set the standard for treating infants as early as they're diagnosed, as early as possible on the basis of this clinical trial. But even these children, treated from 7 to 8 weeks at that time, still now that we're looking at their brains with MRI imaging and functional MRI imaging as they age into middle childhood, we're seeing, these have been the best cared for children you could find in Africa in terms of HIV treatment and monitoring, surveillance, and yet there are significant problems through diffusion tensor imaging in the white matter pathways. When you look at a more detailed the integrity of that white matter brain pathways within the brains of these developing children using, for example, fractional anastrophy. With these children who look normal, who neurologically, even neuropsychiatrically seem normal, yet there are significant problems emerging. And they're emerging even in these children who have been maintained on antiretrovirals from infancy. Now, unlike South Africa and East and West and Central Africa in the Sub-Sahara, we've got a significant comorbidity risk. In the area where we work, it's one of the highest infection rates in the world for malaria. And the moms who are HIV positive have extremely high lows of placental malaria. So these kids are getting malaria exposure gestationally. And we're now we're adding neurodevelopmental outcomes to a University of California, San Francisco ongoing clinical trial, treating moms who are pregnant with HIV and moms who are not for malaria prevention, and seeing if we can enhance developmental outcome by minimizing placental exposure to malaria. But there's a host of other comorbidities in these kids, and if it turns into cerebral or severe malaria anemia in early childhood, that's one of the big hits that neurodevelopmental trajectory can take. That it'll set the stage for the entire lifespan of adulthood. 1 out of 4, in fact, we've identified at school age as having ongoing neurocognitive impairment who have survived. 20% of these kids don't. but the kids who survive cerebral malaria are marked and really are at about a 40% risk for development of seizures and epilepsy as well. So now that we're keeping these kids alive into adolescence, into adulthood, and we're seeing these adults age, some going on 3 decades of disease and HIV management, we all know that the chronic diseases are becoming a huge issue. As African adults in general age, and those in the low and middle income countries globally, what's the impact of cardiovascular disease in basically maximizing the risk related to neurocognitive and neuropsychiatric dementias, and how does that push that threshold for Alzheimer's disease and vascular-related dementias ahead? And so in your patients where you're seeing biomarkers and clinical risk factors for these types of chronic diseases and HIV, you'd better be looking at their neurocognitive and neuropsychiatric well-being, because it's probably significantly at risk as well. Coming back to the first 1,000 days, we know what to do. The Lancet published a series now, 2016. It was a follow-up to their 2008 series. And at all the various stages of the first 1,000 days and beyond, through middle childhood and to even adolescence, we know what works. We've got evidence-based interventions. It's just the political will and the prioritization. Why do this? Why prioritize it? I'm coming back to my trajectory, right? You set that stage early in the first 1,000 days, and it continues. The benefits continue across the lifespan for your patients as adults with HIV. But poverty, it all occurs against the backdrop of poverty. I've highlighted Sub-Sahara Africa here, and I want to look especially at these 2 far right-hand columns from 2004 to 2010. The percentage of African children who will achieve their maximum potential in light of the United Nations sustainable goals for this millennium, and the vast majority of kids will not. 3 out of 4 will not, and that hasn't changed much over the last 6 years. If we look at 2004 to 10, and probably that hasn't changed much up to the present if we had those numbers. So Mahatma Gandhi said that the greatest tyranny is poverty. And all that we're talking about, and this is not irrelevant to the broad spectrum of impoverishment between West and Eastern Europe and the migrant populations now that you face, that we face to some extent in the United States, but especially here within the EU. Migrant children and populations who've been traumatized, who've come here terribly at risk, maybe with HIV and at risk for that, maybe not. But family income, parental education will affect brain structure. And we have evidence of that now based on a Nature Neuroscience publication in 2015. It seems like not so long ago. But this publication was seminal because parent education in years being related to brain volume in their children with neuroimaging evidence. We talk about that, we kind of know it, but to have this kind of neuroimaging evidence, to see it in the brain of these children, to see the relationship between family income, and especially on the lower ends in the poverty line area, and brain volume, the cortex, the cortical structures. Again, I'm coming back to that trajectory in the first 1,000 days. To see that evidence as we follow cohorts, like the Jamaican cohort that was given nutritional intervention and play therapy with home health care visitors, Grantham McGregor's classic studies out of Jamaica. Now these kids have been followed into early adulthood and beyond, and how that early stimulation set the trajectory, again in the first 1,000 days, to how they now succeed or don't economically within their communities and what they give back. And the earnings of that treatment group that got the intervention for nutritional deficiency, that received home visits from the healthcare, that taught the moms how to play with the kids. Now we follow that same cohort and have looked at the subsequent generation. And now here we're getting into epigenetics. And the more we're learning about how environmental experiences changes the genetic structure and moves multi-generationally, now we're seeing evidence that early childhood stunting, poverty, impacting on the next generation, maybe up to the 7th generation, going to the Old Testament. So we've talked about this interrelationship, this triangle between culture, gene, and brain, and all the cutting edges in a recent co-edited, well, again, not so recent now, but a more recent series sponsored by the NIH Fogarty Institute. One of the articles in that special issue looked at neurodevelopmental disorders. Another one of those articles, led by Leslie Davison, focused specifically on adolescence and all of the neurological, mental health, and substance abuse risk factors in adolescence. You can see a list of them here. We've been talking about some of them, but they're not just for adults, depression or anxiety. They're in kids, and they're especially in adolescence. As we look at all of the various important factors, and these are, because the majority of these kids we've got millions of them in each of these African countries where I work, of non-infected but exposed kids who are now moving into adolescence. And at the last 2018 AIDS meeting here in Amsterdam, just in July, there was quite an emphasis. In fact, the second virology education workshop on adolescence and HIV is coming up, I think next month, in Cape Town. That the risk factors that we can see, depression, anxiety, other kinds of traumatic brain injury, and risk for drug abuse, early sexual debut, how's that going to impact on the ability of these kids to adhere to their medications for the rest of their lives as adults, if they're HIV patients, or if they're hepatitis patients, or they're cardiovascular patients, because it's a balance between their executive functions, coming back to the brain, how that stage was set in the first 1,000 days, and impulsivity and emotional processes. That's how the adolescent brain is balanced. And so Leslie Davison does a great job in her review. But we're seeing already evidence, both in infected and in exposed, cognitively, neurodevelopmentally, and also in terms of mental health. Claude Mellons at this Amsterdam meeting led a special pre-meeting workshop specifically on mental health risk in youth, and in particular adolescents, now that our cohorts of kids are surviving in adolescence with HIV, and far more children globally surviving in adolescence, exposed but not infected, and they seem to be very much at risk as well. We've been looking at some interventions, computer cognitive games, with our outcomes being sensory motor, behavior problems, and cognitive ability, all of which we've tried to validate against functional benefits like school achievement, activities of living. But you got to adjust all those for what's the factors that I'm showing you here on the left: psychosocial risk, poverty, the great tyranny, biological risk and comorbidities, and then, of course, the interface to direct treatment and its efficacy. So we're also looking at interventions. I mentioned 10 years worth, training the moms in interventions of their young children, both exposed and infected. We do home visits, we do videotaping, evaluation as the moms bathe their kids, feed their kids, do shared work, like what you see here, and play with their kids. And we look at how they're training once every couple of weeks over the course of a year, how long it lasts after you stop training, and what ways we can do to sustain and scale up and sustain that training and its impact. Basically, we've documented through repeated publications that if you can improve quality of caregiving in that first 1,000 days, you can improve neurocognitive outcomes for those kids through middle childhood. It's as simple as that. That lays a foundation for the lifespan. I've noted those conclusions here. So both early caregiver training with moms and then computer cognitive games once these kids hit school age. They're going to be playing on their smartphones anyway, on your smartphones in Europe and America and Africa especially. And so what we do in the way of documenting through the most rigorous randomized controlled trials to establish that these games, if harnessed and engineered and targeted in the appropriate ways, can really enhance neurocognitive function. It can be one of the sources of impact on the developing brain through childhood and into adulthood that we can harness and possibly use in a rehabilitative way. We've concluded that we do need...
Michael, can I?
Well, I'm going to stop there, but we do need behavioral as well as medical interventions. We're waiting to hear September 14th at Council for NICHD whether we can combine a new generation of antiretrovirals with behavioral interventions in order to make a greater impact on our kids as they move into adolescence. We'll see if we can do that. Why computer games and will they work? And I've had a lot of NIH reviewers over the past couple of years say, well, you know, it's not practical, not feasible, not sustainable, not affordable, but yet, in the words of George Bernard Shaw, some see things that are and they say, why? I hope at this meeting we're not just going to look at things as they are and say, why? But we're going to dream things that never were and say, why not? Why the heck not? So understanding the HIV neurocognitive across the lifespan starts in the first 1,000 days, risk and resilience. I want to recognize my funders, and I want to thank you for your attention.